Now we'll go to the next lecture. I would request Dr. Anwar to announce the next speaker, please.
It is a great pleasure to introduce a well-known neonatologist, Professor Syed Rehan Ali. Sir is a professor of neonatology at Sindh Institute of Child Health and Neonatology, Karachi. Sir is actively involved in teaching and the training of the neonatologist and has more than 100 presentations at national, regional, and the international meetings. Sir, talk about the management of hypothyroidism in the newborns from screening to treatment. Sir.
Assalamu alaikum, everybody. So, you would say a lot of repetition over here, but I specifically explain my perspective as a neonatologist, what we need to know, and what things have been done, and what path should we take in order to progress further. So I'm just gonna talk specifically about congenital hypothyroidism, screening and management, and summary evidence algorithm, and it is based on European consensus and AAP guidelines. Objectives of my talk is to overview of newborn congenital hypothyroidism, screening, rationale and method for congenital hypothyroidism, outline diagnostic workup after an abnormal screening to show how to treat and monitor, and then follow up in the long term follow up and the transition of care to the adults. So how do I define? There are many ways of defining congenital hypothyroidism. In my mind, simply is the dysfunction of hypothalamic pituitary thyroid axis, which present at birth, which results in insufficient thyroid hormone production. When we are talking about congenital hypothyroidism, there are lots of gaps, and that's the challenge. 70% of the infant worldwide, they born without access of having a neonatal screening. And many of these areas are also iodine deficient. So this is the worldwide coverage over the last 50 years. This has been going on for the last 50 years, probably since 1960s. So when we talk about the newborn screening, what are the principles to do a newborn screening? The general principle been described by the WHO well before, I think it's 1960s. Whenever we are looking at the newborn screening, we have to look at the population frequency. That how prevalent is the disease which warrants screening. And if that disease is left untreated, what's the natural history of the disease, whatsoever we are looking at in the newborn screening. Natural history should be well defined. And the untreated disease could cause a significant morbidity and mortality. That disease should be treatable and improves the outcome. The disease testing should be safe, simple, and sufficiently sensitive to detect nearly all cases. There should be a specific confirmatory testing available for that disease. And the testing, treatment, and treatment outcomes are also cost effective. And these are the principles for screening for a disease that we are doing through newborn screening. So why screening for congenital hypothyroidism? We all know it is a common cause of preventable intellectual disability. All over the world, there are varied incidences. We know that it is common in Pakistan, around 1 in 1,000 to 1 in 1,500. And these babies are so deceiving that they don't present at birth. Only 5%, less than 5% of babies are symptomatic at birth. So, screening by the TSH, doing a TSH, is cheap and easily available. And the one thing which is fantastic is that treatment is highly effective after diagnosis, and we get a near normal outcome if we treat those babies within 2 weeks after birth. On the other hand, if it is left untreated, it causes permanent damage. So, when we look at the age at diagnosis of congenital hypothyroidism and the outcome of IQ, the first column you can see is the age in months from 0 to 3, 3 to 6, and greater than 6 months. And you can see the remarkable difference if this disease is left untreated. There is an IQ average outcome for early treatment of 90 plus if treatment started within 2 weeks. And if it doesn't, or if the diagnosis get delayed, you are unfortunately having an IQ of less than 55. Some points about thyroid physiology in pregnancy. Probably other speakers have also mentioned this. We know that placenta is permeable to iodine, TRH, and antithyroid drug, but on the other hand, there is very limited transfer of TSH, T4, and T3 across the placenta. The maternal role in the first trimester is fetus is only dependent on the mother and the only source to the fetus. Maternal T4 transfers, it usually increases by second and third trimester to protect against hypothyroidism. Now, when we look at the fetal thyroid gland maturation, as I said earlier, if you can see in the slide that the maternal thyroxine dependency goes down and fetal starts producing his own thyroxine. But look at this area of hypothyroxemia of prematurity between 22nd and 36 or 37 weeks of gestation, where these babies are vulnerable when they are born preterm. They have hypothyroxemia of prematurity. In terms of neonate, we do know that there is a TSH surge. Within 30 to 60 minutes, TSH surge begins immediately after birth, probably secondary to the birth process and the cold stress. And then in 6 hours, it peaks up, as you can see, very sharply within the first 6 hours in the picture. And then it can reach up to 70 to 80 milli-international unit per liter. And then there is a rapid decline in the next 24 to 48 hours. And this is the time where screening is timed to avoid these false positive window. In terms of preterm, there's a different scenario. Preterm infant, they don't get any surge, they have no surge. It may not occur. They have a delayed rise in the TSH. And the T4 level in the preterms may fall initially before it starts normalizing on day 4 and day 5. So the implication for these samples collected before 48 hours in term infant can have a high false positive rates due to physiological surge. In terms of etiology, we do know that there is a permanent, transient, and less common etiology behind congenital hyperthyroidism, permanent being the dysgenesis, agenesis, ectopic, and disharmoniogenesis. And the transient are secondary to the maternal thyroid antibodies, iodine deficiency, exposure, and some less common like central hypothyroidism and thyroid hormone resistance. So what would be our choice of test when we are looking at congenital hypothyroidism? There are two types of screening. One is the primary TSH based screening, which is quite sensitive and specific, but then it may miss central hypothyroidism. It does not detect the delayed rise in TSH like in preterms. And the second screening is the primary T4 based screening with or without TSH backup. Obviously, it is ideal to detect primary as well as central hypothyroidism, but it does not detect the compensated hypothyroidism. So, in this type of screening, there would be a higher false positive results you can find. So, primary TSH screening was adopted by most centers worldwide and is the recommended strategy for Pakistan. Now, when to sample? As I said, the first 48 to 72 hours to avoid physiological TSH surge. This would be the ideal scenario. And if the mom is going home early, less than 24 hours, which is the usual scenario in our government setup, you can collect a sample, but TSH, if the TSH is borderline, it must be repeated. Now, in terms of preterm and sick, you follow the protocol of your institution, you do the initial screening, and then you repeat in 2 weeks. There are two ways of doing bloods in these babies. One technique is taking a cord blood, which is collected from the placental side of the umbilical cord, not the baby side. So, wipe the maternal blood, collect 3 to 5 ml, store at 4 degrees centigrade and transport. So that's pretty easy and simple. You don't need to touch the baby, you don't need to harm the baby, or there would be no iatrogenic pricks or anything. You just have to collect 3 to 5 ml of blood and send it to the lab. The other taking is the DBS with the dried blood spot technique, which is, we also call it the heel prick technique, which is done in the lateral side of the heels on both sides. And you make sure that the whole circle, full circle, is completely filled by the blood. Then you dry it horizontally for 3 to 4 hours at room temperature, and do not stack all the wet cards together, and do not touch the area where you have dropped the blood. Now, the usual assays used in the test, serum, cord blood sample were analyzed by ELISA and CLEA, and dried blood spot by immunofluorescence and caloric method. Just to show you that how do they measure, like TSH measure from DBS is expressed as whole blood unit, and the TSH in serum units is equals to the TSH in whole bloods times 2.2. So if the TSH in whole blood units reported as 9 milli-international unit per liter, equivalent TSH serum unit will be 9 times, it means the whole blood times 2.2, which we normally see in the laboratory monitoring. When they give us the result, they give us in the serum units, not in the whole blood units. So the screening pathway, at a population level, you do the neonatal blood spot, this most sensitive test, you measure the TSH, it is either normal or abnormal. And then you can add, depending on your strategy or resources available, you can also do the T4. And once the abnormal test obtained, then you do confirm it with the serum sample. And if the free T4 and the TSH clearly above the age-specific reference, then you start levothyroxine immediately. And if the TSH at second week of life greater than 20, you start treatment even if the FT4 is normal. So even if the TSH is more than 20, you start the treatment. If the serum TSH beyond 21 days of age and there's a normal FT4 and the TSH is between 6 to 20, we can suggest either start treatment immediately or reevaluate at a later date, or withhold the treatment and repeat the test in 1 to 2 weeks. Now, just note on central hypothyroidism that if serum FT4 is low with a low, normal, or elevated TSH, consider central hypothyroidism. Start levothyroxine only after ensuring intact adrenal function, because we know once you start the thyroxine, there is a rise in metabolic function which alters the cortisol, and then there is a so make sure that the baby doesn't go into adrenal crisis. So who needs repeat screening? In some situation, initial screening may miss congenital hypothyroidism, so a second sample is indicated at 2 to 4 weeks, like these preterms, IUGR, sick neonates, multiple births, Down syndrome, and first sample after transfusion. Evaluation, history and physical examination, history, and history. You go with the, see if there is a consanguinity, if there is a perinatal autoimmune thyroid disease, if there is a maternal iodine exposure, any dysmorphism in the baby, or anomalies like cleft palate, congenital heart, and hypotonia. You do the imaging, identifying the etiology, hearing screening is recommended, and the X-ray knee to show the absent lower femoral epiphysis, which is suggestive of severe congenital hypothyroidism and corroborates with later neurodevelopmental delay. Now, there is one option when, if you can, an antenatal ultrasound can be performed to assess looking at the femoral epiphysis, and it determines the severity of intrauterine hypothyroidism. So, role of imaging, we can do, the cardinal rule is start thyroxine treatment before conducting the thyroid gland imaging studies, either at diagnosis or at 3 years holding treatment for 4 weeks. The common methods we use is the ultrasonography, which is non-invasive and cost-effective, and it determines the presence, location, and size of the thyroid. And then you do the perchlorate testing, which is the radioisotope scintigraphy, which is most accurate for determining the etiology of thyroid, like if there is an ectopy or athyrosis, how's the function and uptake. So the recommendation is imaging the thyroid gland using either scintigraphy, ultrasound, or both. This is the thyroid gland. The first picture shows a normal uptake in the eotopic gland in situ with a normal salivary gland uptake. In the second picture, there is no uptake at all, which shows agenesis or blocking antibodies. The third picture, which is the uptake at the base of the tongue. And the fourth picture is lateral view for the uptake at the base of the tongue for localization. And the last picture is with an increased uptake, which is usually we see in goiter. And when we see that, there would be no salivary gland uptake in these situations, in dysharmoniogenesis. There are some surgical implications of congenital hypothyroidism. And we come across like these children could have macroglossia. There's a potential for subglottic narrowing. It is difficult to intubate these babies. Cardiovascular effects can happen, like bradycardia, decreased cardiac output, temperature instability. They can also have a delayed gastric emptying, delayed wound healing, and there's a recommendation that preoperative optimization is required whenever possible to review and do the hormone replacement. In terms of levothyroxine, we do 10 to 15 micrograms per kg as a single daily dose. Higher dose should be used in severe cases if the T4 is very low and TSH is very high, which indicates agenesis. After crushing the tablet, it should be mixed with breast milk till 6 months and then breast milk or water after that. Adding tablet to feeding bottle should not be attempted. And these iron, calcium, soya and vitamin should be avoided 3 to 4 hours of giving thyroxine. The importance of uninterrupted treatment should be discussed with the family to halt the neurological damage. So navigating the first years, monitoring for optimal development, the goals is to achieve rapid normalization of the serum TSH and FT4 concentration above the upper limit can be accepted. And you assess the growth in a neonate and then tenor staging in older children. So the recommendation is the first follow-up 1 to 2 weeks after starting thyroxine, then subsequently every 2 weeks until TSH normalize, and then every 1 to 3 months until the age of 12 months. And this is takes you through from 0 to 12 months. Just one nuisance is the reduction in thyroxine dose should not be based on a single high free thyroxine unless the TSH is suppressed or there is a clinical sign of overtreatment. Long-term pathway further on from toddler to a teenager, again ages 12 months to 3 years, you decrease the frequency of the follow-up from 2 weeks to every 2 to 4 months, and then after 3 years, until the growth is complete, evaluation should be carried out every 3 to 6 months. There are some situations where you need to increase the frequency if you're thinking of non-compliance in these patients, or if you have changed the dose, so you can increase or decrease your follow-up after that. So when to reevaluate these children, whether these children needs a lifelong therapy or we should stop. When no definitive diagnosis of permanent congenital hypothyroidism was made initially, there should be a re-evaluation at the age of 2 to 3 years. And this is particularly important for the children who have a gland in situ on ultrasound. So if you're seeing a child who you have done the ultrasound and there is a gland present, there is always a chance that this child might come off treatment. So how do you do that? You stop the treatment or you phase out over 4 to 6 weeks, and then after 4 weeks of treatment, you measure the serum FT4 and TSH, and if the TSH is greater than 10, then that's a permanent disorder and you need to restart treatment. But if the TSH is less than 10, that could be a transient treatment, no treatment needed, and you continue to monitor this child. Generally speaking, if there is a situation where there is a gland in situ and the child requires less than 3 microgram per kg per day of thyroxine at 6 months, re-evaluation can be done at 6 months of age rather than at 3 years. Neurodevelopment, we know that early therapy have markedly reduced the prevalence of intellectual disability from 8 to 28% to merely less than 1%. We anticipate if there is an over or under treatment, there is a low parental education, if you do a few follow-ups, then all these problems like reduced IQ, attention deficit do occur. So what would be the destination? Achieving a normal and healthy life. We try and promote normal growth, final adult height. This should be the aim. Fertility does not differ from individuals who do not have congenital hypothyroidism. Physically, they should have a normal bone, metabolic, and cardiovascular health. But you keep continue looking at their neurodevelopment periodically, especially at school time, for a speech delay, attention deficit, memory problem, and you do repeat the hearing test before school age. In terms of genetic counseling and testing regarding congenital hypothyroidism, this should not be general, it should be targeted. Again, there are tests like next generation sequencing, which is, if available, can be done. Antenatally, diagnosis is indicated if there is a fetal goiter on ultrasound and familial recurrence of dysharmoniogenesis, which puts the baby at higher risk, about 25%. And you do the ultrasound at 20 to 22 weeks and you evaluate fetal thyroid volume. In terms of fetal treatment, if you feel there is a large fetal goiter with hydromenose and it is causing tracheal occlusion, then intraamniotic thyroxine injection is recommended. So what about the studies in Pakistan? We have done, we looked at the studies from Pakistan from all across. Our incidence is around 1 in 1,000, 1 in 1,500. This is the experience from my center where we have done about 8,274 samples. 114 samples were rejected. Tests performed on these. Screen positive were 85, and these 85 were all responders. Confirmed positive was 7. The non-responders are the one, they were not in screen positive. I guess probably by the reason because whenever there is a screen positive results comes, then we just do everything to try and contact these parents. But these are the 20s which are non-responders. So our incidence came out to be around 1 in 1,166. So what are the pillars of lifelong success? Education, education, and education. The problem we face that the parents don't think that it is a significant disease. You need to spend time, tell them about the diagnosis, and tell them that this might go on throughout their childhood and later. And they need to adhere to the treatment in order to influence outcome. The main aim is the continuity of care, and all individuals are entitled to a well-planned transition. So, guidelines are there, as I mentioned in my talk, from European and American Academy of Pediatric, and the consensus is very clear. this is the pathway, what they are doing worldwide in terms of congenital hypothyroid screening. Ultimate goal is to fulfill a promise, healthy, productive life for every child with congenital hypothyroidism. And this is concomitant to ensuring optimal neurodevelopment, growth, and lifelong well-being. I don't know if there is, I don't think that DBS or serum screening is mandatory by law in Pakistan. I know that there is an act in Sindh Assembly in 2013, sir, and that mandates that every child who leaves the hospital should get at least, serum or the DBS. But I don't know, what we are doing. This is significant number, 1 in 1100. The Europe or USA, they are 1 in 4,000, 1 in 3,000, 4,000 they are. Our incidence is very, very high. So I think this is a fruit to think about for the policymakers. It's a very cheap test. Probably around in hundreds, not like 200 or 300 rupees. And the thyroxine, 100 tablets of thyroxine cost around 200 rupees. So 200 rupees test and a 200 rupees of treatment, that saves one child for every 1,000 babies. Thank you very much.
Okay, thank you, Professor Rehan. We have got around 10 minutes for question and answers on the last two presentations before we disperse for Juma prayers. Okay, the first question Professor Talal is going to ask.
Thank you very much. I think I'll start off with it. My question is, probably Dr. Haq is the right person who can answer this question. Since we have discussed some transient adrenal inactivity also, is there a role of using hydrocortisone as a single dose for sepsis in preterm babies?
You're asking a different subject. Role of hydrocortisone in sepsis. Yes, there is a role only when there is significant shock. Otherwise, there is no reason to use hydrocortisone in sepsis. There is no reason to use hydrocortisone in sepsis unless the baby is in shock.
Junaid wants to ask.
Same thing, Talal, that the sepsis is we are treating with the antibiotics, okay? And when the baby went in shock, we have to see the blood pressure, the trend of blood pressure. And if it is not routinely maintained, then the last resort is the hydrocortisone. So one dose hydrocortisone I never use. Maybe sir can tell.
There is no definite regulation of when you should use it, but usually it's a last resort, and we use 0.4 or up to 1 milligram kilo.
Okay, I have a question for Professor Rehan. I think a good presentation on hypothyroidism. The question is, have you seen any mother-baby pairs with iodine deficiency? Because I had a few babies with neonatal goiter where I examined the mother's thyroid and they had enlarged thyroid. So both the mother and the baby were having iodine deficiency. So both were treated. So whenever we encounter neonatal goiter, I think other than hormonogenesis in underprivileged societies like ours, we should consider iodine deficiency goiter also.
So we do ask in the history, but in fairness, I've never come across a baby, probably in your area, in your side, that is quite common.
Okay, the other question is, I think Professor Taid Bhatt might answer.
Just as a query that it was believed some time back that maintaining thyroxine level when you are replacing it for the baby's congenital hypothyroidism. The intellectual outcome and the neurodevelopmental performance is slightly. Is that true? Because there was a talk of a few, maybe a decade back, but now we don't hear that because there's generally a fixed dose and trying to maintain it in the higher normal level, and just close to the upper level. So, is it still held? The opinion is held that it helps.
As you said, that's correct. But you also have to follow the TSH as well. As long as the TSH is okay, you tend to ignore slightly higher levels of uh, T4.
No, we just talk because sometimes we come across patients where maintaining T4 at a normal level requires a relatively, somehow you can't really help it, but the TSH level stays a bit higher on the higher side. So we come across these situations every now and then, but that is why I have a question that if we try to maintain T4 in the upper normal range, does it help?
To me, to be honest, it certainly helped giving me an idea that all I needed to do is that I'm not over treating the baby. But as I said, in my mind, will not go.
Is there any evidence in the
Okay.
literature?
I don't know, to be honest. About Sir is asking that is there is any evidence that keeping the FT4 on a higher level, higher normal level. I don't know.
Thank you very much, Professor Rehan, for nice presentation. Though my question is related to your topic, but it is more from peds endocrinologist. What I see in my practice, so many patients have hypothyroidism. I'm following them and they are on treatment. But at the age of 3 to 5 years, in between these age, I see them that they have got a component of attention deficit hyperactive disorders, or they have got a component of autistic spectrum disorder. So is there any relation, it is part and parcel of the disease, or these are the complication of the thyroxine therapy?
As I mentioned in my presentation, that when you're treating congenital hypothyroidism, you evaluate the baby and look for other possibilities as well, like congenital heart, like any dysmorphism. So there is always an association of congenital hypothyroidism. We do see the books do describe like Pendit syndrome. They are comes along with hypothyroidism. So primary congenital hypothyroidism per se should give you a good results once you have treated that baby. When I showed you the IQ level, there's a remarkable difference, like intellectual disability from 28% to less than 1%. So the babies you were talking about is probably they would have some sort of dysmorphism or some sort of other intellectual disability. All these new generation sequencing probably will answer these questions for you.
Okay, there is another question, I think.
Assalamu alaikum. I'm Dr. Afia Gul. My question is from Dr. Rehan for the excellent presentation. Sir, when we see the neonates, they have the shock and multiple inotropes and they have the steroids, all they affect the thyroid function test. When we say
Say again.
So, when we talk about the sick neonates who have received inotropic sport, steroids, and the things like that, that affect the neonatal thyroid function test, what should be the ideal time of screening in those particular term babies? And the same is true for the preterm. When should we go for the screening? Should they be delayed? Specifically in our circumstances, when there is a big chunk of the neonate that is going to be lost of follow-up, and we will miss the hypothyroidism.
That's the thing what I said, that even if they are going early home, you still do you still do it. And if the TSH is borderline, then you call them back. But again, in your case, they are lost to follow-up. So before they will lost to follow-up, I would suggest to do it, the TSH.
So,
Is that? Yeah, yeah, go ahead.
so my second question is regarding the incidence or are there any studies, because I was unable to find the studies which are showing the preterm hypothyroidism data from the Pakistan. There is any studies regarding those showing which pattern of the hypothyroidism is seen? Because in our center we usually see the babies who have the low value of the TSH and the low value of the free T4 and who stand sometime nowhere. Should we treat? Shouldn't we treat? What are the symptoms? What are the symptomatology? And how should they monitor?
I think the lady is here to answer your question.
I disturb the lady a lot.
My take for this situation is I would definitely start thyroxine and I'll follow the child back and then I'll take it from there. So I would not leave that child
So you will
without
be,
getting.
so you will keep.
So there's a small comment. Whenever the baby is really sick in preterm, the concern is missing hypothyroidism because the TSH is normally
Yeah.
suppressed actually. That is why you need to recheck. But if the baby is sick and TSH is high, please treat. It is hypothyroidism. So
If
there's
the
no
TSH
problem.
is, Dr. Sumaya, my question is, if the TSH is low
Yeah, so that is called sick thyroid.
and T4 is again low,
Okay, so that I'm saying, so you have two differentials. Either it's a sick thyroid or central hypothyroidism. In that scenario, you just wait for 2 weeks and repeat another set of
Yeah.
tests. And in case if it's persistent, treat it. It's better to
so
treat
it's
it.
a
But
compulsory to
but
wait
they
for the
lost
2
to
weeks.
follow.
Lost of follow-up.
Yeah.
My question is the lost of follow-up.
Yes. You need a very tiny dose of thyroxine. Central hypothyroidism do not need a very high dose. And to be very honest, central hypothyroid kids, they used to present to us at the age of 10 years and 11 years. And somehow, they do not have mental retardation and they do not have neurocognitive problems. So that chunk, that is why is not a part of newborn screening program across the world. Central hypothyroid is actually not the NBS program across the world because it's not affect neurocognition. So you should concern about primary hypothyroidism with high TSH, which is definitely gonna positive if within after 48 hours, treat it.
So,
Thank you very
I
much.
think- Can I
Yes.
comment one thing?
I
Sorry.
think we have to break for Juma
Yes.
prayers. We
Thank
can
you very
continue our discussions in the lunch break. So thank you very much, all the distinguished speakers for enlightening us with their lectures, particularly
Sir,
Professor
first
Haq,
we-
Dr. Sumaya, Khadija, and Professor Rehan. So now the session is over and we have to go for the shield distribution.
जी जी
Yes, please.
Thank you very much for
Shield distribution will occur. After the shield distribution, we break for prayers.
for souvenir distribution. I would like to invite Professor Salman Ali. Sir, please. First souvenir is for the Professor Khalid N. Haq Sahab. Sir, please. Hey. Thank you, sir. Professor Syed Rehan Ali. Sir, please come on the stage. जी. Yes. Professor Khatija Humayun. Sir Rehan will receive the souvenir for Professor Khatija Humayun also. Dr. Sumaya Aftab. Now I would invite Professor Khalid N. Haq Sahab to please sir come on the stage to present souvenir to our chairperson. Yes. Yes, yes. Yes, sir. To Professor Salman Ali, sir, please present the souvenir to Professor Salman Ali. Professor Amin Jan. Thank you. Brigadier Talal Bakar. Sir, please. Hafiz Anwar Saab. Hafiz Anwar Saab. Now all the chairperson will present souvenir to me. Thank you very much, sir.